It's really good.
Just to flip through the slides.
Okay.
Yeah.
Might get I'll think they're up first before we have the panel rather than maybe
I think you're the
So that they don't have to set. Yeah.
Right, well, we better get underway. I guess a meeting that starts on time finishes on time, which is always a fine thing in an evening meeting, or any meeting, but particularly an evening meeting. So welcome everybody, both here in person and online. I'd like to start by acknowledging traditional custodians of the land which meet, the Kumameri people, saltwater people, and Aboriginal elders past, present and emerging. My name is Nick Zwar. I'm the Executive Dean here at Health Sciences Medicine. I'm also a GP. And many years ago, part of my PhD was on antimicrobial stewardship. And so I'm kind of very interested to hear how the field has changed over all that time. And I hope that we'll be able to contribute something to the discussion. So my job really is just to chair tonight's session, introduce our first presenter, Professor Alastair Hay, all the way from Bristol in the UK. And I think you've been doing a bit of a tour around various other places. I know you've been down in Melbourne, Alastair. And then once we've heard Alastair's presentation on some of the international perspectives on antimicrobial stewardship, we're going to have Paul Glasio talk about the Australian perspective on what's been happening here and all the work that's happened here at Bond and other places. And then we've got a panel, including Professor Gerben Kleises, who's here from the Emergency Department at Gold Coast Health, and Dr. Ashley May, a GP who has the real world experience of trying to manage this in primary care, as I do my 1 day a week, and Mark does, and some others here as well, when we get a situation, and I'm sure Alastair, you do in your practice as well, of how do we deal with this in the real world. Mark Spanner as well, as a full-time GP, you get it every day of the week, I'm sure, Mark. How do we manage this challenge? So I might at this point hand over to Alastair, and we'll hear a bit about the international perspective.
Do we think that'll work? Great, thank you so much for that introduction, Nick. I'm going to move around until I find the place that feels about right. But if it doesn't feel right to you, just say. So I'm going to talk a little bit about how I think insights from UK antimicrobial stewardship policy might have a bearing on Australia. And also, we're in the process of refreshing our public health policy in the UK now. So I'm going to offer a few thoughts as to how I think we might go forward. So these are personal views rather than policy, but I will be part of the process of establishing the next 10-year policy as well. And of course, the timing's perfect. You've just had this report published. And among other things, I believe it says that primary care is sort of under-recognised in terms of its role in curbing resistance. And I think I'll be talking a bit to that during the next few minutes. So hold on to your seats. So just to introduce myself, so 80% of my current time is spent as a professor at the University of Bristol. So that's my office on the left there, as I left a couple of weeks ago. And I've got the privilege of leading a group of folk, multidisciplinary team who are interested in all things antimicrobial stewardship. So if it's to do with diagnosis, or it's to do with treatment, or it's to do with resistance, you know, we get interested straight away. So 1 day a week equivalent, I work as a GP at Concord Medical Centre. They tolerate me there with great generosity. And part of my role, as well as delivering clinical care is to lead the practices research unit. Now, that's a unit that delivers other people's research. It's part of the clinical research network within the UK, which has been such a success story in terms of things like Panoramic and Principle and the other trials that have demonstrated benefit for treatments against COVID. And in mentioning that, I also want to just mention that I stand really on the shoulders of many giants who have had the foresight to invest in the UK in research and in clinical research networks. So some of what I'll show you, you would be doing if you were in my shoes, I have no doubt. I'll give a little short summary of the problem, AMR, and why it's relevant to primary care. I'm going to give you a quick whistle-stop tour of recent UK policy. And I'm also going to talk a little bit about how that might have impacted on AMR, and including some, I think, global first results. Global, although Melbourne has seen them, so forgive me if you're feeling a little bit unhappy about that. And then, as I say, a little bit about future strategic direction, and then some time to discuss things and summarize. So Jim O'Neill will be familiar to those of you who are interested in this as a topic. He's a UK peer, sits in the House of Lords, and he was commissioned by Dame Sally Davis and others to write a report about the global impact of AMR. And what he determined is that 10 million people will be losing their lives to AMR by 2050, and that by then it will have cost the global economy $10 trillion. So he was really sort of putting the case for why this is a government level problem, as well as a public health problem, as well as a problem that we all face in our clinics. And already as a GP, I'm encountering problems related to AMR, mainly for people who have urinary tract infections. Now, I understand that here you're not quite seeing the same level of antimicrobial resistance in your urinary tract infections, but trimethoprim has been the go-to first-line antibiotic in the UK for the last 20 or 30 years. And we now see resistance rates exceeding 40% in routine samples sent to laboratories. So for certain groups of patients, it's no longer our first-line antibiotic. And one of the things I'm going to cover is how we've pushed now to using nitrofurantoin instead as first line. Now, you've only got to have a patient who's got an allergy or who's pregnant or who's got poor renal function, and you're starting to be backed into a corner, even as a GP now, in terms of urinary tract infection management. The middle picture there is a slide showing MRSA, which of course was a big problem 10, 15 years ago. And it's probably through infection prevention and control measures that has been curtailed. But we have a growing problem of sepsis in the UK as our population ages, and I think you will be seeing that as well here, increasing mortality, and we're also seeing increasing proportion of antimicrobial resistant sepsis in the UK. So this is very much front and center of UK public health sort of strategy and thinking. And in the community, we are responsible for prescribing over 3/4 of all health service antibiotics. And that's a global phenomenon. So if there is a solution to AMR, then primary care is absolutely central to it. However, when I talk to my clinical colleagues, this is the sort of thing I hear. I have never had a GP come up to me and say, do you know, Alistair, I'm part of the problem. I overprescribe broad spectrum antibiotics. You know, it's me. And if I'm honest, I don't know whether I'm a good prescriber, which I think is an appalling state of play for somebody who's supposed to be an internationally regarded expert on antimicrobial resistance. And I don't know if I'm a good prescriber. So we'll come back to that. But this was a bit of a red rag to a bull for me. And this got me and our team thinking, well, if it's not me, if people don't own the problem, what is it that we can provide that will make them think again about that? What would make you think, well, actually, maybe I am part of the problem? And so we set about a whole program of work trying to see what the evidence is that links individual GP prescribing to AMR. Is there a relationship? And if so, how strong is it? And the first of these studies was published in 2010, and my colleague Kira Costello, who's now a professor in London, led this study. And it's essentially a systematic review of randomized controlled trials looking at the problem where the antibiotic could feasibly have been prescribed in primary care. And what this review showed was two things. First of all, it showed that for urinary infections, there's a demonstrable link and that it is time related. Now I'm hoping that so the top triangle here shows the relationship at or within 1 month, and it's showing that the odds of having a resistant bacteria in the urine in the month after a prescription of antibiotics is 4 times what it would be if they hadn't had an antibiotic. And that relationship persists at 3 months, with the odds being elevated 2.5 times. It persists up to 6 months, with the odds being doubled. It's a kind of nice time relationship there, waning with time, but nonetheless demonstrable, certainly up to 6 months. Other studies have shown possibly up to 12 months. Now that's routine antibiotics in primary care. Same was shown for respiratory bacteria, although not quite with the same sort of time-bound relationship. But nonetheless, within a month, the odds are doubled. Within 2 months, they are still doubled, starting to wane by 3 months. That's for respiratory bacteria. That's routine antibiotic prescribed in primary care. My colleague, Ashley Bryce, then married Hammond, produced similar results published in the BMJ in 2016 from her PhD, this time in urinary bacteria from children. We looked at the relationship between individual doses of antibiotic and resistance, and this was a sort of tag-on study amongst urinary bacteria, showing that for each individual trimethoprim tablet, 200 milligrams, the odds of resistance went up by 1%. 10 tablets, 10%. 14 tablets, 14%. Dose-response relationship. We then looked at the relationship between prescribing in primary care and nasal staph, and in particular MRSA. These are staph that are carried in noses, so this is not disease-causing bacteria, but carried. And again, we showed a relationship between routine use of antibiotics in primary care and subsequent isolation of MRSA in noses. And finally, a small study, but nonetheless demonstrating a signal that what we prescribe in primary care not only affects bacteria that are relevant to subsequent presentations in primary care, but for patients who are admitted to hospital. So if they've had a recent antibiotic in primary care and they then have a urinary tract infection that requires hospital care, they are more likely to have a resistant infection as a result of the primary care prescribed antibiotic. Okay, so that I hope starts to convince some of the people that might be thinking, it's not me. I think it's all of us. It's every single one of us. So what have we been doing in the UK about this? Well, when I was very early on in this whole game, 1998, this was the first publication that I was aware of. At this point, I think it was still regarded as sort of not quite front and center of UK policy, until Dame Sally Davis hit the scene. And as Chief Medical Officer for England, she started banging the drum for AMR. And I have to say that probably many of my colleagues in the UK owe a lot of what we've done to Dame Sally, because she's been able to bring the prioritization processes for AMR research to the fore and made us competitive with some of the other big ticket items like cancer and neurodegenerative diseases, for example. And following her interventions, a series of reports have been published, including Jim O'Neill's report and the latest one, which is now currently being refreshed, each of which have outlined the UK's strategy to deal with AMR. So what have they included? So there's been a lot of public health messaging. And certainly pre-pandemic, when people were still sitting in waiting rooms, they would usually have TV videos promoting antibiotic stewardship among patients. So, for example, the Keep Antibiotics Working campaign was very important. And I'm pleased to say that some of our work directly informed the messages that were being given in that campaign. The Antibiotic Guardian is an initiative that anyone can sign up to. So I am an antibiotic guardian, and any of us in the UK, and I guess globally, can sign up to be an antibiotic guardian, and we can display kind of stickers and badges and posters and things in our consulting rooms, for example. And then the RCGP, the Royal College of GPs in the UK, has also been hosting the Target resource for the last 10 years or so, which includes things like patient information sheets that GPs can print off and give to patients that explain things like the natural history of infections, what to expect, how long you should expect symptoms to last, for example, with and without treatment. So all of that, I think, has made the conversation in the consulting room a little bit easier. Now, I can't distinguish the fact that I'm now grey and been a GP for 25 years from what my patients have been learning with me over the last 25 years, but I am not having as many arguments with patients over antibiotics as I once was. And I would quite often find myself using the delayed prescription as my get out of jail free card. I'm not really having to do that very much now. I can't offer you a lot of evidence, but I can just say anecdotally that I think people are more aware of AMR and more aware of it as a reason to think twice about whether they should swallow the antibiotic or request the antibiotic. So perhaps more specifically to primary care, NHS England, as I've alluded to already, started suggesting that we should move away from trimethoprim and move towards prescribing nitrofurantoin first line. And they set up what was called the quality premium, in which they promised CCGs, which were the area organizations at the time, each looking after in the order of 1 million patients. They promised them that if they met certain targets, they would not take away £80,000. So generous, not even a large amount of money. But you set a CCG a target and they start working towards it. And they did have antimicrobial stewardship pharmacists who started to take an interest in this. Now, the specific targets were that trimethoprim prescribing should increase, trimethoprim prescribing should decrease, nitrofuran prescribing should increase, that overall prescribing should fall in relation to a previous level for that CCG, and that broad spectrum antibiotics should not account for more than 10% of total prescribing. Those were the metrics that primary care was set at the CCG level. And this is what followed. So we have seen a steady reduction in prescribing in the community ever since. And of course, that's been further suppressed by the COVID pandemic and lockdowns. Probably there's been an escape since, which we can come back to if we want to. But of course, that's not causal, that's association. And unless you want to tell me that our quality premium in primary care in the UK helped Australian prescribing fall, we're definitely looking at something that's association, not cause. Having said that, my colleague Ashley and I and a few others did an analysis of the impact of reducing trimethoprim prescribing on AMR among routinely submitted urine samples at the GP practice level. And what we demonstrated was, yes, trimethoprim prescribing had fallen. Yes, nitrofurantoin prescribing had increased. And yes, trimethoprim resistance was falling in routinely submitted urine samples to labs at the GP practice level. nitrofurantoin resistance did not increase. So far the news sounds good, but cefalexin and coamoxiclav resistance were increasing. Why? We don't know. We're looking at association, not causation. And the next step, of course, if we're really going to understand whether this is causal, is to do randomized controlled trials. And I'm really pleased to say that the NIHR has now funded a program of work in which we are going to conduct a series of randomized controlled trials in which we go to different parts of the country in the UK who have a specific AMR problem. We're going to discuss with them what the potential solutions might be. And then we're going to intervene with a complex intervention to support GPs, nurses, pharmacists, reaching for a different first-line antibiotic, not stopping prescribing, but just trying to encourage them to use something different. So, for example, it might be something like pivmecillinam if they have a rising nitrofurantoin resistance problem. And as a little bit of background to that, I just wanted to share with you some slides that I shared with Paul and team earlier, and do just give me a nudge on the time if I'm starting to run short. Thank you. In which what we've started to do is look at resistance rates by CCG in England between 2017 and 2022. And what this slide and the subsequent slides will show you is changing patterns with time. And I think this is the first time this has been demonstrated. Whoops. Shouldn't have done that. Right. So first thing to say is each area is a CCG. If the color is darker, then the resistance rate is higher. And in this case, this is trimethoprim resistance in E. coli, with the darkest blue indicating 30 to 40% resistance. The next bar down indicating 20 to 30% resistance. The next bar down, 10 to 20% resistance. Now I'm going to show you a series of slides that flick through the same trimethoprim resistance over the years 2017, 18, 19, 20, 21, and 22. And I want you to tell me what you think you see. Are you ready? See it again? Is it the eye of faith, or do you think the colors are actually getting lighter? Possibly they're getting lighter. Okay. What about nitrofurantoin resistance? That's the thing we've been trying to encourage GPs to prescribe instead. So here's 2017, and then I'm going to show you the same series of slides, 18, 19, 20, 21, 22. Perhaps less clear. Certainly, perhaps a little bit of something worrying going on down here. Less clear. Now, that's a first stab attempt, okay? And Ashley worked hard to get these ready so that I could show them to you here. What we plan to do next is to do the same analyses, but at the GP practice level. So it'll be far more granular, and we'll be able to show individual GP practices what their rates are and what the impact of their prescribing is on subsequent resistance rates. So that's the plan. Okay, I think I'm starting to run out of time. Paul, is that right? 2 minutes. So personal view, where are we going next? I think we're going to find that all the strategies that we use will link with one another. There's no single magic bullet to solve this problem. We're going to dissolve the iceberg from lots of different directions. I think we're going to keep on seeing public partnering. I don't see that changing. We're going to see more of the eBug program, which is a school education initiative so that the youngest generations are aware of antibiotics, infections, and resistance from an early stage. I think we'll probably see more of the Antibiotic Guardian program continue. I think that infection prevention and control will be really important. And I think vaccination is going to be a central pillar. And I think we can probably expect to see a growing number of surfaces that have antimicrobial properties coming into everyday life more and more. I think the question about air purification and cleaning is quite a live one. We did the systematic review that shows, yes, these filters clean the air. There's no question about that, but there's no evidence about the impact of that on human health. So we're currently running a trial where we're seeking to see whether putting air filters in care homes could reduce infection incidence among residents. I think we're going to see more guidelines for what it's worth, but I think that those guidelines need to start to be integrated into the electronic medical record, so that as a GP or a nurse in primary care starts to type in sore throat or cough or whatever it might be, the relevant guideline will appear as a pop-up and they can quickly see what the guidance says. And we know that decision support helps. So there's already evidence that Mark Gulliford and colleagues have produced to show that if you've got the right type of electronic medical record integrated decision support, it can improve prescribing and it can do that safely. I think we'll also need to continue to monitor prescribing, and my personal sort of mission here is to see each and every clinician in a position where they can receive their own prescribing data in relation to their peers. Because if you talk to clinicians, the other thing they say is, well, I do all the infection clinics, so there's no point in comparing me to, you know, Professor Hay, who hardly does any work at all. So what we'll then be able to do is to start to peer reference against similar groups of clinicians, so you can see whether you're the outlier or not. That doesn't improve appropriateness, it only helps to improve the variation in prescribing among groups. I think we're going to see point of care tests coming our way. And I'm happy to talk about that a little bit more if people want to discuss it. But we are, as I was mentioning to Paul in the group this morning, we are currently running a randomized controlled trial, not just to see whether they change prescribing, but more importantly, to see how they are influencing prescribing. Because at the minute, it's a bit of a mess. Come back to that if you like. In the UK, there is a huge push to bring other professionals into the frame, and pharmacists are kind of like in the crosshairs of the government. And that may be exactly the right thing to do, but nobody knows whether they do a better job or a worse job. We don't know. And my big concern is that what we might end up doing inadvertently is just increasing demand, because for every patient that we see in primary care, probably there's another 10 or 11 who have chosen not to consult at the minute. But if we make access so straightforward and simple, I think these people are just going to come in anyway. Particularly if we start doing lots of fancy point of care tests, that's just going to medicalize them even further. So I think we're up to the kind of summary and discussion point. What I've tried to do is give a brief overview as to what the evidence is that our prescribing in primary care actually makes a material difference. I've then given us a quick history through what the UK has been doing, and I've given a quick glimpse as to what I think we might do in the coming years. So over to us for some discussion, and Paul, I think, has got a few slides as well.
So thanks very much, Alistair. That was a great overview of the problem, first of all, and the nature of the resistance and its relation to the amount of antibiotic prescribing, particularly important at the individual level. So I think the problems in Australia are very much the same, but the policy response has been a bit different. And if I can work out how this clicker goes. Yep. I'm just going to set the scene with a few Australian things, and then we're going to have the panel discussion. So first thing to say is the nature of the problem in Australia. This is data from 2014 that John Turnage, who's one of the great sort of doyens of antimicrobial stewardship in Australia, was fond of. What it shows here is Australia's community antimicrobial use compared with other countries, and it doesn't look good. So we're prescribing about 3, maybe 4 times the rate of Sweden. Interestingly, in Sweden and Australia had almost the same rates in the 1990s. Sweden then took it seriously. They're now, as you can see, the #1 country in the world. A few years ago, they overtook the Netherlands as the lowest prescriber. And they've had a national program called Strama that's been ongoing the whole time. So it reminds me of Eddie Cantor, who was a singer, once said it takes about 20 years to be an overnight sensation. And Sweden is the same. They've been, this isn't a one-off magic bullet. As Alistair said, there isn't any magic bullet for this. This has been a steady drop of about 7% per year has been the reduction in Sweden. But that accumulates over time. And that's where they now are from being the same as Australia. And it's because of our lack really of a national program to do things. We have had some programs, and I'll mention those in a moment, but just to illustrate the nature of the problem in Australia, as one of the first studies that the Kramark group here had done, we looked at, this is Amanda McCulloch, Chris Delmar, myself and others, looked at the beach data for the appropriateness of prescribing. The reason we could do this is that the beach data was collected with more detail. GP would do it for about a week, collecting random consultations and provide more data on that. And because there was enough data there, you could check the appropriateness of the indication, which you can't get out of most medical records. So the beach data was done. And what you see here is this high rates of inappropriate prescribing, with the worst being the, where is it, bronchitis, the second one there, which surprised us. So it's the thing that most needed attention, really. Sinusitis, then bronchitis, and less so for otitis media and sore throats, which had been the ones that Chris Delmar and I had been focusing on. And it made us realise we needed to refocus attention, as in Nina's shared decision-making trial. So what's happened since that data that John Turnage showed? There has been something as a drop. This is the slide from the ORIC data 2021 report, but only goes up to 2019. Same data you flip through very quickly, so I'm going to spend a moment more on it. But same in Australia, we've also had a huge pandemic drop in the number of antibiotics prescribed, but we don't know what the long-term impact of that is. And particularly a concern has been with telehealth, perhaps increasing the rates of antibiotic prescribing because of the greater uncertainty there is during a telehealth consultation, particularly without video. So there is a small drop you can see. So that was probably the NPS, but again, correlation, not causation. So the National Prescribing Service was the one national group that used to try and do something about antibiotic resistance. And they did that through periodic community campaigns, the sort that you were talking about, Alistair. But they would only do that every, say, 5 years. It wasn't a yearly program like Strama. And they would also do that with GPs, particularly through academic detailing of fairly large numbers of GPs to get education to them. And they did this fancy Bayesian analysis that said that there was this quite, substantial effect in reduction. And I probably believe them because it was about the only thing being done at the time to reduce it. But it's been pretty steady since then. You can see no change really from 2016 to 2019 because NPS hasn't had another national program. They were planning on one, but as we know, NPS has now been defunded. So it won't be happening in the next year, maybe not for several years. And several of us in the ANZGRIN network, which is the Australian equivalent of the GRIN network, were so concerned about this, we wrote to the health minister to say something needs to be done to replace the antimicrobial stewardship role of NPS in general. And what might we do? I'm just going to mention one last thing, and that's a study that was led by the University of Queensland, us in QUT, looking at the sorts of things and the effect of combined intervention. So practice poster is one, patient pamphlets giving out information to patients, delayed prescribing where we had little stickers that you could put on the prescription to say this was a delayed prescription. The near patient testing was very popular, but dangers to it, and patient decision aids. And Marlene Pelstrip, the middle person here in the poster that you can see, she's back in Denmark now, and she was telling me the influence of the point of care testing in Denmark was an initial drop in antibiotics, but then it's been going back up as patients have become dependent. They now think, oh, I've got a sore throat, I need to come in to get my sore throat test. And so long term, it's probably counterproductive to do that. And so we still need to know what the short-term impact but also the long-term impact of different mixes of these interventions are. And with that, I'll pass on to the panel if they can kindly come up here.
Great, thanks, Paul and Alistair. Well, I might ask the panel to come up. So we've got Paul and Alistair, thanks, Paul, on the panel, and Gerben Pfeiffer from Gold Coast Health, and Ashley May. So welcome, everybody. So I guess we might start by perhaps posing some questions or responses and thoughts to Alistair's presentation and Paul's summary of the Australian situation. Maybe if I can start off and others might comment, one of the things that I think has been probably less successful in Australia and less sustained is community awareness or change of viewpoint and attitude to antibiotics. And I wonder if people agree with that contention or not, and if so, why might that be, that we have not had the same level perhaps of convincing the general public that antimicrobial judicious use is a good thing to do. I might ask you first, actually, do you agree? I think I'm completely wrong, or what would be your perception?
Among younger patient populations, and so young parents and things, I would say that there is more awareness about unnecessary antibiotic usage, and they're more aware of the impacts of that. But amongst my older patients who are determined that they need Augmentin with a repeat for their urinary tract infection, because theirs is a really, really bad one, I'd say those ideas are really quite fixed in some of my older patients. So that's what I see. And that's, but I think it's much easier to convince those younger families and things and educate them about the implications of unnecessary antibiotics in their kids and family.
I think some of your older patients and my older patients must overlap a little bit. Interesting comments from others. Maybe Paul first,
So I think that's right, that there is a pretty modest community awareness of the problem. NPS was running those periodic campaigns, which I think helped, but it's not a sustained thing as we've seen in Sweden. And we certainly need more of that. France ran a very successful long-term campaign on antibiotics and not automatic or not mandatory, which helps change the population. So not finding the nice slogan, which sounds better in French, was a very effective strategy. But the other thing I'd add is, actually, we have a huge workforce for training patients and educating them about antibiotic usage, because almost every Australian sees a GP every year. So maybe we should think about them as they're doing the same sort of thing as the NPS service, but for patients. We should be educating patients better on the individual level, but we need to help GPs to be able to do that by handing out information leaflets, decision aids that Asmin has been testing and producing, which actually educate the GPs probably more than the patients.
Okay, Mark,
As a kind of add-on to your question, I'm wondering whether the message that's been out there for 30 years is a bit tired, is that more antibiotics equals more community resistant, and that's a problem for everyone. I remember having conversations as a GP trainee circa 96, or little weren't being prevented. It hasn't changed. Whereas I'm more taken, and I find it more efficacious when talking to patients about the personal harms versus benefits, and that resistance that might last in you and maybe your household for up to a year after a course of antibiotics actually holds a lot more sway than the sort of global warming. If I give you these antibiotics, it'll be bad for the community.
Yeah, I'm interested in others' comments on that. I mean, one of my interests is travel medicine, and it's been shown if you have antibiotics for Travers diarrhea, you're more likely to come back colonized by extended spectrum beta-lactase resistant Enterobacteriaceae. And then if you have your prostate biopsied and it gets into your blood, you're in serious trouble. And when you say that to someone who's going traveling, oh, I'll pass on the antibiotics, thanks. I'll just, use a bit of Lomitil or something. So I wondering comments from others. Gerben, do you think is that personal message something that comes across in the emergency department or in the hospital system, or what do you think?
It's obviously very complex. So I'll start by saying that I'm Dutch and I did my medical training in the Netherlands. And we were very upset that we got overtaken by Sweden.
Yes.
But what I can say is from my medical training is that it is part of the culture. And I'm not sure how you change that culture, because the culture in the Netherlands, and I'm not sure it has to do with the way we educate students and then become doctors, or whether it has to do with the way general practice is organized, which may be more similar to the UK system than the Australian system. So I think that there's probably multifactorial components why the cultures in those different countries are so different. But I remember my sister has a few young children, and she sometimes give me a text that says, if they're 41 and they're shivering, but they're still watching television, and I think it's just a cold, is it okay? So probably. But it shows that they're not worried. They're just saying, oh, I'll probably just text my brother who lives 24 hours away, rather than rushing to the GP. So I think that it shows that they've sort of accepted that it's fine. So they didn't even want to give Panadol because they were still watching television. So I think that what it highlights is some cultural differences. I think in the ED, it's sometimes tricky because we obviously see a subset of what you see. And I think there's probably a different expectation pattern, which makes it a bit harder. And it also means that I think our doctors in the hospital setting, they've already filled the home situation, they've filled the GP interaction, or they're not filled, but they've managed to come to the ED. So I think our threshold changes as a result, rightly or wrongly. So I think that adds to the picture, but I think we over-prescribe antibiotics much the same, and we probably over-prescribe intravenous antibiotics in a similar way. And I think that's partially that's cultural component of that. We think that because something hasn't got better, people need something done, and there's an intervention bias, and this then ties nicely back into the work that we're doing here at the Institute, and Paul's doing about natural courses of what's the natural course of a condition. I think we don't know enough about some of the natural courses that we confidently can say it's okay to be a bit sore and a bit uncomfortable and a bit febrile for at least another 3-4 days.
Yeah, Alistair, I think that natural history thing is an important point. In your comments, yeah.
I couldn't agree more. And one of my concerns, as I've alluded, is that if we keep on providing better and better services, we're going to just simply end up chasing our tail, and we're going to have more and more people expecting care. And for me, a key message there is helping the public determine whether their infection is a normal infection. This is just, part of everyday life. We all get fevers, we all get coughs, we all get colds, we all get earache. Doesn't mean we need to see a GP or come to the emergency department. So if that's the case, then how does a parent or a patient know when they should come? So I think for me, one of the key future kind of areas of research and work is helping our populations understand what is a normal infection and when is it ceasing to be normal, where they should actually start to seek help. Because those are people we want to see, right? We want to be able to help the people that we know will benefit either from non-antibiotic treatment or the few who may well benefit. But we really want everyone else to stay away from us if they can, because as soon as they walk in the consulting room, there's a very high chance they'll leave with an antibiotic, irrespective of whether they actually needed it.
Okay. Comments? Mark, you got comments from your experience? Yeah. We all do, all of us. It's a very good one.
seem very important. And my concern here in Australia, when we're looking at the pharmacies being able to prescribe, and you saying keep them out of the GP's office, but they're going to go to the pharmacist who's has a financial gain to prescribe a medication, is going to prescribe it. But we don't see anyone stopping that at the moment. Some people are talking about it. So I think the problem is actually going to get worse. The second point is if you look at the anti-smoking campaign, how successful that was, but even on the antibiotics showing you how bad the cigarette is. If we had on antibiotics, if we had the adverse effects shown on those antibiotics on that box, you know, would the person pick up and say, oh my God, I can get this disease because I'm taking that? Perhaps I should think twice about it.
It's an interesting idea. Yeah. Yeah, I guess once you've got the box, you've already bought it. But yeah, that's yeah.
Second time.
Yeah, you might change your behavior. Yes. Yeah. Yes, Mina. Yeah.
I have multiple points. The first one is about we did a qualitative study with patients, letting them know that actually resistance can stay up. Letting them know that resistance can.
Hold it. Yeah. Hold it close. Yeah.
So we did a qualitative study investigating whether patients are aware of how long the resistance will stay in their own body and that actually resistance can be transmitted. And what we found is that patients were very concerned that actually they didn't know. And when they knew that it would make, they told us like, I will double think about asking and demanding an antibiotic prescription for any of my acute infections. I would rather wait it to go away until I get better and not take an antibiotic treatment. So, so that's the first comment. So we investigate that, and I think delivering the message may help somehow. We are working on with Kwame as well on producing patient information sheet to give to the pharmacist. You know, as a way to communicate the natural history, so that because one of our colleagues studies, she mentioned that there are referral link from pharmacies to GPs. So maybe we can try and cut this link, like reduce the referral, like when the patients receive reassurance that they don't actually need to go to the GP right now, maybe they can wait a couple of days. Maybe this way will help a little bit, reducing the patients going to GPs.
Mm-hmm. Yeah. Yes, Gavin.
Copy 1, 2, 1, 2. Yep. So I'm providing obviously a hospital view. I think one of the things that, and I'm not quite sure that this really aligns with how primary care works, but within the hospital setting, I think anecdotes carry a lot of weight, and we have morbidity, mortality meetings. And it's always that one patient that seemed to be okay that ends up with necrotizing fasciitis or horrible sepsis and has a poor outcomes, and it gets highlighted and emphasized. And as a result, it gets, you know, those stories, they bring emotions. And as a result, I think that leads to fear and maybe an incorrect perception of the true risk of those things actually happen. I mean, they're in an M&M meeting for a reason, because they're probably rare and they're probably system failures rather than individual failure. But I can see that, especially when I talk to junior doctors, to be safe, to be sure, we may as well. They say those things because there is this sort of fear that they can't really put their finger on and quantify appropriately. But I think that I can see that as partially part of the problem within the hospital system. I'm not sure how that works for yourselves, because you may not get the feedback on the patients you see who may get a better outcome. But that definitely is a thing that plays a role for us.
Yeah, I think that's absolutely true for primary care as well. That a lot of prescribing is done, we know, because of fear that this is the patient that might be the one that deteriorates. And then we'll be sort of, with the benefit of hindsight, we'll be sort of asked by the parent or the patient, you know, why didn't you give me an antibiotic? And for the sake of all that trouble and hassle, we might as well kind of err on the side of caution. So one of the ways around that I can hang on for a second, is clinical prediction rules. So if we can try and identify the people who are at highest or indeed lowest risk of poor outcome, that may be one way out of this. I don't know if you want to build on that point, because I want to just make another point about the kind of immediacy with which many of our patients want an answer or a solution. A bit like your sister, maybe, you know, I've got a child who's got a high temperature. What do? Call the GP. And I just wonder if some of the future interventions are going to encourage our patients to just take a period of time to watch and wait, which is what we do all the time in primary care as clinicians. And I wonder if there's a kind of generation of people who perhaps want an instant answer, but we might need to be encouraging them to, we'll see how your child is, or how you're feeling in another hour or two. You know, if you're feeling the same way, then maybe have another think about it.
A quick question
Yeah.
from online.
Mm,
So this is from Emma Bailey,
mm.
and she goes, I think the concept of keeping patients out of the GP clinics who don't need to be there is so important. In pharmacy, we're actually trained to refer patients with symptoms of acute otitis media or tonsillitis or coughs lasting more than 2 weeks, etc., for further assessment. And she has some questions for the panel. That is, do you have any suggestions for pharmacist educators about how to train a pharmacist with regards to symptom-specific referrals? Currently, we aren't given diagnostic skills to determine the severity of symptoms.
Alistair, as a visiting expert, you have to get to answer that.
So as it happens, I am working with colleagues in the UK to try and put together the resources that we think pharmacists might need to help them make the right decisions. And I think that the sad truth is that there is some evidence out there to help us, which is good, and we should use that where it's there. But actually, a lot of the time, what we're ending up doing is what so many guideline committees have done is they've found that there's a lack of evidence. And so we're having to try and make things up, you know, by common sense and consensus. And the real danger there is that these 1 in 1,000, 1 in 10,000, whatever they are, events actually drive all of the thinking. And that we always sort of, the common denominator becomes, how do we identify the child with meningitis? Or how do we identify the adult with sort of prodromal sepsis who's got a UTI? And don't get me wrong for a minute, those are really important things to do. But if we allow that to constantly drive our thinking, we will always end up in the same place, which is, if you're worried, ask for help. and that just simply won't take the conversation any further forward. So I think somehow, and again, I wouldn't want to be misquoted, but you know, child health and child mortality is the lowest it's been in hundreds of years. But children are going to continue, and adults are going to continue to die of sepsis and severe infections, however hard we try to reduce it. And somehow I think we've got to get that message out there that, you know, the health service is there to protect and treat people, but that even with the very, very best will in the world, we're not going to always get it right. And we shouldn't be treating everybody in order to try and protect that one individual. Now, that's a really tricky message to get out there. And already I can feel, you know, myself thinking, oh, I shouldn't have said that, you know, that's wrong. That's going to get misinterpreted. But I think there is something in there that we need to try and tackle.
I think one thing we could do is consider the counter narrative. So just as a quick anecdote, a GP colleague of mine once had a patient with a urinary tract infection. They came back 12 months later, looked at the card, he said, oh, how did you get on with that urinary tract infection? And she said, I wound up for a week in the PA hospital with Stevens-Johnson syndrome and was really, really ill, nearly died. That's the sort of counter narrative of the rare adverse effect as well. And I think we actually have to keep that, the harms in mind, and get people to think that it's always a balance of risks. It's a risk, one risk versus another risk. And that's where your clinical prediction rules will come in. And Stevens-Johnson syndrome, of course, is incredibly rare. The bigger the real risk, but it's harder to explain, is the one that you mentioned right at the beginning of your talk, is that you're going to have an infection where the antibiotics don't work, and it's an individual problem, and you may die of it. And we're seeing, I think it's 2,000 deaths a year in Australia from antimicrobial resistance at the moment, and that's just set to get worse. But they're not as easily visible as the child who dies of the missed meningococcus.
Yes.
Thank you very much. So I'm trying to reverse the pharmacist equation where we worry about community pharmacists prescribing or providing some sort of care for patients who come to them. And then we talk about GP prescribing and the sort of gatekeeping role that pharmacists can play. Because in a number of hospitals where excessive prescribing, pharmacists have been able to play critical gatekeeping role where they have vetted prescribing or prescription practices and have given sort of advice to limit the number of prescriptions. And so within the community pharmacy and then GP prescribing, what sort of linkages do we have such that pharmacists within the community can actually see what a GP is prescribing matches against the symptoms and the diagnosis and everything, and perhaps do some sort of intervention to the GP to say, we think maybe you need to relook at your prescription practices when it comes to this. What sort of linkages do we have? And then when it comes to the communication, I think Mark spoke about it and Mark also talked about it. I think it's very critical because in places where there are cultural differences and sort of messaging is not considered within the cultural context, it becomes a big challenge. And probably that is why we are not seeing any change in certain places. Because I remember some time back when the WHO and a group came with superbug, in certain countries, they said, oh, superbug, it means that you need a stronger medicine to cure them because they are super. And that is what actually moved them from using simple antibiotics to prescribing very broad spectrum higher antibiotics because they wanted to cure the superbugs. And so you really need to look at the communication within the context. And finally, Alistair, you spoke about global perspective. We all agree that AMR is a global issue, but most of the research and all of us here, our concentration is in Australia and UK. And we look at the number of people that moves into Australia or the UK every year, and there's nothing happening within their environment. So they come with their culture, their practices and everything within the country. And that has a rebound effect on our use of antibiotics. So how do we look at it as researchers within Australia and UK, thinking about what might come in from other countries and how we can collaborate with researchers in low and middle income countries to really look at the situation?
Gosh, there's a lot there. I'm glad that Ashley's going to help us with this. But perhaps firstly, that communication and teamwork such that it is between community pharmacy and general practice. Because I think it's quite a different context to the hospital pharmacy, but I might ask Ashley to comment.
Yeah, I think the hospital pharmacist has a very different role, and I remember them being very efficient and useful in keeping everybody online with their prescribing. Community pharmacy and their communication with general practice, I guess, is a little bit different. And I think there's probably a lot of GPs that don't want to hear feedback from the community pharmacist about, whether they've done the right thing or not. But in coming here tonight, I went and had a chat to our pharmacist in the practice there and was quite shocked to hear that she reported that it was quite common for GPs to prescribe, say, Sofradex drops, so antibacterial ear drops with 2 repeats on the script. They're prescribing trimethoprim. They might follow the guidelines, 1 at night for 3 nights, but give a script for 7 and a repeat on that as well. And so low-hanging fruit like this, I was really shocked to hear that, my colleagues, might be doing these things that I guess, have a big impact on patients' appropriate use of antibiotics. Because if they've got a half-open packet of antibiotics at home, they're just going to pop them the next time they think they need to do that. So I don't know how to improve that feedback from the community for other than going and asking and saying, you know, and to find out what the problems are. But there's no formal channels that she has to really feedback unless she, you know, talks to us individually, which I can understand she might be hesitant to do. I don't know that that's a comfortable conversation. We've also had a lot of issues with antibiotic supply, I guess, lately. I don't know if you guys have found the same thing, like amoxil for kids being out and sort of the pharmacist saying, okay, well, we've all got to use Augmentin. Oh, okay, all right, sure. It's a bit uncomfortable, but that's,
that has been an issue.
I'd love to, I think feedback for prescribing practices is probably really important, and whether MPS used to play a big role. And I think it's really sad that we're not going to get that feedback anymore. So maybe there is a role for pharmacy stepping up and giving us that feedback to make us look at what we're doing with a different view.
Yes, Alistair, and I'm conscious of time. What time are we meant to finish? It's like now, is it? Or pretty much now? Yeah. Okay.
Just to float perhaps an idea, I'm not sure. I think what we're starting to think in the UK is that the pharmacists have a kind of general medicine optimization role. And I don't know whether that's the case here in Australia. So it's not just about antibiotics, it's about prescribing across the piece. And often it's about costs. It's often about ensuring that we're using the lowest price version of whichever medication it is at the current time, or the one that the locality has managed to be able to negotiate a particularly good deal with. And I just wonder whether perhaps some of the future might consist of that being part, the antimicrobial stewardship being part of the medicines optimization role for pharmacists.
Yeah, we don't have as much that system here. I remember visiting a practice in the UK years ago when I was there, and the pharmacist came in and talked about, you know, the pattern of use within the practice, had a lot of data about it, and the GPs were there and listening. Whereas since NPS, and even then, I mean, they did have some data, but I don't think we've had anything like that for quite a long time, for people to actually sit down and talk about their data and their own practice and reflect on it, unfortunately. Whether that can be resuscitated somehow, but we haven't got it right now. Any final comments before we thank our speakers and panelists? Marks? Yes, sorry, yeah.
Sorry. I think one thing that I've found the more I've been working in this space is that we all talk about the appropriateness of prescribing, but to define appropriateness is actually quite challenging. And if we look at work on, you know, if you pick one particular infection, if you look at the evidence for it, there is probably a spectrum of what may be appropriate, and then there's a whole spectrum that's inappropriate. But yeah, the guidelines can vary from jurisdiction to jurisdiction as well. So I think that the whole component of appropriateness is an interesting concept that probably needs a bit more thought, and it probably highlights, you know, the lack of evidence to make sure that practice variation isn't that large. I think that probably plays a part. So appropriateness, and we did some work on looking at a month worth of data in the emergency department, which was 8,000 patients, of which 1,000 got antibiotics, so 1 in 8 rather, 12%. And an antimicrobial stewardship pharmacist, microbiologist, infectious disease consultant, and an emergency physician sat together and decided based on the NAPS guidelines, which is National Antimicrobial Prescribing, whether this was appropriate or not. And 1/3 was inappropriate, but a lot of this stuff led to big discussions. There wasn't definitely a clear consensus. So it just highlights how complex the concept of appropriateness is.
Yeah, and I think one of the things I think we worry about or think about in a randomized trial, which compares one group with another group, you may not get a difference in outcomes, but there's probably individuals in there who did get an difference in outcomes. And how on earth can you pick them? Which is, I guess, your point, Alistair, in a way. Is there, and others, is there a pattern? Can we get better at picking the ones who actually would benefit, and conversely better at picking those who wouldn't? Because currently it's a bit broad, isn't it? And I remember when I first started as a GP, my knowledge of the natural history of some of these conditions, I didn't have it. The hospital training had never taught that. So how long is it going to take to get better, doctor, for my urti? You know, yeah.
Always longer than you think.
Yeah, always longer than you think. Yes. Yes, and we've got a tendency to say it'll be about 5 days, where actually it's more like 10, whatever, it is. We tend to be too optimistic and then people get disappointed and they come back. Anyway, that's probably, yes, sorry, last comment. Yeah.
Just to add to what you just mentioned.
The question is, where were you expecting to find the natural history information from? In guidelines, obviously.
Well,
Delayed prescribing, he mentioned, mostly guidelines. But surprisingly, in one systematic review that we did, guidelines that focuses on these acute infections do not mention natural history. So there's very limited information in these guidelines, where as a GP that practicing wants to get the information about natural history will not find. And so it's important that perhaps we improve that sort of information, delayed prescribing natural history in clinical practice guidelines, so that the information will be available to clinicians and GPs that use those guidelines for treatment.
yeah, it's a good point. I mean, I think in education too, the exposure to hospital medicine and not so much to primary care, you got less opportunity to see the natural history of those things too. That's changed a fair bit. So well, I think we better thank our audience, thank our panel. I just got a little ad for the practice-based research network generally for GoldNet. Thanks, Amanda. So thanks. This is our first face-to-face event for the year. And it's been great to have Alistair and the panel contribute to that. This is one of the studies that's going on at the moment, activating primary care COPD patients with multimorbidity. So if anyone is interested in that, please get in touch. And there's a whole cast of organisations involved in that, including Bond University. And we're actively recruiting practices at the moment through till June this year. And there's a few other opportunities on the website, I think, Amanda, as well. We will have another evidence-based journal club in the not too distant future, I hope. And we're looking for suggestions on topics for that. So if people have suggestions on the topic, then that would be very welcome. And then also suggestions for another face-to-face event later in the year, which would be at Griffith University. We usually alternate between here and Griffith. Anything I've forgotten, Amanda, except to thank you for your organisational work?
And Ali.
And to Ali, yes. And thank our panel and thank all those online who took part. Mark's going to go home and reflect on his status as a confessed prescriber. We're all going to go reflect on that. but yeah. But don't feel you have to have a drink to cope. Okay. So thanks everyone, and thanks very much for your attendance and all that interesting discussion.
Thank you.
Or food left outside if people still want to.